Hi, everyone. This is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer, and I'd like to welcome you to today's Journal Club. We're really very excited to have this Journal Club, to have this opportunity to discuss with this stellar group on this particular study. I want to also thank ESGO and IJGCS for their support always of our Journal Club. So we're really very excited to do so and have this discussion. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. So the participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentation. If you're having any difficulties or questions, please send a message through the chat, and our technical support team will assist you. So with that, I wanted to again thank our presenters for this month's Journal Club. This is going to be focusing on the lead article titled "Prognostic Value of Isolated Tumor Cells in Sentinel Lymph Nodes in Low-Risk Endometrial Cancer, Results from an International Multi-Institutional Study" by Giuseppe Cucinella, a former fellow of the International Journal, Andrea Mariani, and Gretchen Glaser at the Mayo Clinic. So I am very pleased to welcome them to join us. I want to thank all three of them for being with us today and sharing their insights into this really great article. So I'm going to hand it over to you for the overview of the article, and then we will start our discussion.
Okay, so first of all, thank you, and thank you everyone for this opportunity. And I want to spend a few words on this slide. It seems boring, but I'm grateful to all the people that are listed in these slides, are all the authors and all the members of the different centers. And so it was a very big effort, and I want to thank all the centers that contribute with the cases and their help to this achievement. So thank you very much to everyone. So next slide. Looking at the left side of the slide, so talking a little bit about the background, the first question that moved also our study was, why is so difficult to understand the real behavior of the ITC, so the patient that have isolated tumor cell in the sentinel lymph nodes. We need this piece of the puzzle to understand really this behavior. We need enough number of patients, and sometimes the past series has a small number of patients. We need an adequate long follow-up. Also, the adjuvant treatment, there is a variability among the adjuvant treatment among different institutions because there is no standardized treatment for the ITC. We need to understand if there is a group of ITC that is a very low risk and doesn't need treatment. And then we need data about patients who receive postoperative observation only, because in this way, there is no influence by the adjuvant treatment on the real behavior. So we can really understand the real behavior of this type of metastasis. And then something that we need is for sure a comparison with a population that is node negative with the same characteristic. So with all these points in our mind, we try to overcome this limitation. And our aim, the goal of our study was to evaluate the prognosis of patients with ITC in the low-risk endometrial cancer by comparing the prognosis of this type of metastasis with patients with negative sentinel lymph nodes. And our inclusion criteria were here in the box. I want to highlight that were very strict because they were FIGO stage 1A endometrial cancer with low grade, so grade 1 or grade 2. Myometrial invasion was less than 50%, and no one of our patients had adjuvant treatment, neither brachytherapy, external irradiation, or chemotherapy. So all had observational only. So at the end, we compared 452 node-negative patients to 42 ITC patients. Another point is that all the population of node-negative is coming from one institution, that is Mayo Clinic, while the 42 patients are coming from 15 centers worldwide. Next slide. And here is just a summary of the results regarding the oncological outcomes of this population. We showed, and we looked at the recurrence-free survival, the non-vaginal recurrence-free survival, and then also the overall survival. And we showed that there is a difference, and there is a prognosis is worse in the group of ITC compared to the group with non-negative. We also look at the non-vaginal recurrence-free survival, and this difference was still significant, while this difference is not significant in the overall survival. So it seems that there is no impact in terms of overall survival. Then if you look at the row in the other part of the slides, we also performed the same analysis after exclusion of patients with detected lymphovascular space invasion. So we excluded 7 patients from the cohort of ITC and 7 patients from the cohort of non-negative. Here again, the recurrence-free survival, there is a signal, is not statistically significant, but there is a signal that there is a difference. The non-vaginal recurrence-free survival is a significant difference in the ITC, while even in the group without LVSI, the overall survival was not different. Next slide. So in summary, our study had something, so we showed that the patient with ITC and low risk profile, so FIGO stage 1A, endometrioid cancer, grade 1 and grade 2, who didn't receive adjuvant therapy, so just observation, had the worse prognosis than the counterpart non-negative with the same risk factors and characteristic, while the overall survival was not impacted by the presence of ITC. Next, really next, because what is next is the endo-ITC, and it's our prospective multi-center study, and we will talk about that. Is something that we are running right now to look at the prognosis of these patients and understand better the behavior, the management, and the follow-up of these patients. So thank you very much again to all the collaborators, and thank you for this opportunity.
Thank you, Giuseppe. That was an excellent presentation. And I do want to also encourage the audience to submit your questions through our platform. Before we start the discussion with our fellows, I wanted to ask sort of like a general question, and perhaps I'll start with Andrea. You know, for many years before we had the introduction of sentinel lymph node mapping in endometrial cancer, we followed this thing called the Mariani criteria. I don't know if you remember that. And you know, basically, I remember that, you know, we would send the uterus for frozen, and you do remember it, I see. So we would send the uterus for frozen, and if the uterus was grade 1, grade 2, less than 50%, then we were done. We were very happy. So then my question is, you know, do you think that there's really any impact from isolated tumor cells when, in fact, before we didn't even really care where there was anything in the lymph nodes because we actually didn't even evaluate the lymph nodes? So interested in hearing what your thoughts are.
No, certainly, again, those criteria, the Mayo criteria, or you call them the Mariani criteria, but are really focusing on a subgroup of patients that are low risk. So they are patients that basically are less than 50% myometrial invasion, grade 1 and 2 endometrioid, but with a small tumor, a less than 2 centimeter tumor. So it's really a subgroup of these patients. Overall, what we noticed is that the probability of recurrence in that subgroup of patients was extremely small, almost negligible, no matter of what you do. If you do just hysterectomy, you don't need to do radiation, you don't need to do chemotherapy. So there is for sure, this is really a very low-risk group, and this is what we recognize. And we are really studying this low-risk group to understand is does ITC make a difference or not? And that's really the question of this journal. But thank you for asking this question.
Great, excellent. Thank you, Andrea. And as anticipated, I suspected that there will be many questions coming in. So we already actually have a question from the audience before we go into the questions from the fellows. And Gretchen, I'll turn to you. This question is, and of course, obviously, very hot topic these days, the new FIGO staging. Does that mean that if you have an isolated tumor cell, in a high-risk, low stage, should this be upstage? Should these patients be given adjuvant treatment?
I mean, maybe I can start by saying, gosh, I wish we knew. I wish we had data about this. I think it's one of the things is it's important for us to all be speaking the same language. So I would caution against upstaging, like kind of going outside of the FIGO staging with ITC and calling someone a different stage. Just, I think we have to ask the question about whether they should be treated or not. But I would say, like, let's stay with the staging and figure out what we need to do for these patients. And then, I think another important, okay, just didn't know if someone had another question. So I think another important thing to look at is how these patients do long-term. In our prospective study that we were just talking a little bit about, we're only planning to officially enroll the low-risk patients, but giving centers the option to also give us information about their higher risk patients. I think that's such an important question, and one that we're going to probably have to answer without a lot of prospective data because that group is small as well. So I think what we're doing at this point at Mayo is looking at uterine risk factors to really make a decision about whether these patients should be treated, have adjuvant treatment, because that's really what we have at this point to make a decision. So, kind of looking at ITC, but also looking at the risk factors.
Excellent, very well. We'll have some questions from our fellows as well. And we'll start with our first question. This is going to be from Diletta Fumagalli. Diletta?
Thank you, Dr. Ramirez. So how do the identified risk factors, meaning the isolated tumor cells in the sentinel nodes and the grade 2 disease and the lymphovascular space invasion, impact recurrence-free survival in low-risk endometrial cancer patients? And also, based on your results, how important do you think each of these risk factors is in predicting non-vaginal recurrence? Thanks.
Well, I can take that one. Sounds really fun. So basically in this study, we showed that those identified risk factors that you just mentioned, so isolated tumor cells, grade 2, positive LVSI, they were all independent risk factors for worse recurrence-free survival in a group with low risk, like we were just talking about, low risk endometrial cancer. So I think the great part about this study, or, there are many great parts about this study, we obviously unbiased. But so I think one great thing about this study is that these patients didn't get adjuvant therapy. So we're really able to look at what their behavior of their disease was without the influence of any adjuvant therapy. So these factors, in terms of your second question, so based on the results, how important do you think the risk factors are in terms of predicting non-vaginal recurrence? So how many of these patients are going to recur distantly? So these factors were predictive of recurrence for both isolated vaginal and for non-vaginal in univariate analysis, and also in a multivariate analysis when we considered our covariate of interest, which is the ITC in the sentinel lymph nodes versus a node negative cohort. And we adjusted those models for predictors. So what was even more compelling was that ITC and grade 2 remained predictive of recurrence even when you took out the negative LVSI. So, or even in the negative LVSI, when you took out the LVSI from that. And then we go into the weaknesses or the opportunities. And this was, even though it's the largest study on ITC, it's also small numbers, limited power. And so we're not able to draw definitive conclusions. And so we need to obviously do something prospective. So I hope that answers your question.
Great. Thank you, Gretchen. And we'll give you a little bit of a break, and we'll pose these next questions to either Andrea or Giuseppe. And looking at combining two questions, because I think they're sort of like interrelated. The first is, do you consider performing molecular profiling on ITC positive patients in your practice? And as a related question, what is the distribution of molecular profiling criteria in patients with ITCs?
Yeah, thank you. If you want, I can start to answer. Regarding the distribution of the molecular profile, our group is working on that, and we presented our preliminary data at the ESGO 2022 by Dr. Gabriela Schivardi. And we grouped together the low volume metastasis, and we shown that about 50-60% are NSMP, so no molecular profile. 30% they are mismatch repair deficiency. The 12% are p53 abnormal, and we had just one case of poly mutation. So we had just one this type of tumor of mutation. In another series also from Mayo that we are working on that, the distribution is similar. So most of the patients with ITC are NSMP. And this distribution, the ITC patients, is equal to a distribution, the typical low-risk endometrial cancer. So if we just recall the number from PROMISE study, from the PORTEC 1, PORTEC 2, the Canadian study, most of these patients, 60% more or less, are NSMP, and more or less 2.5% are p53 abnormal. So for sure, molecular is something that we are working on, that we will also come out with the final results, and maybe they have also a role. But just remind that most of these patients are NSMP.
Great, thank you, Giuseppe. Andrea, at the Mayo Clinic, is every patient now undergoing molecular profiling for endometrial cancer, including p53 and poly and the full scope of profile?
No, right now, no. We are implementing this, and we are going into the direction mostly of starting to do like for excluding patients with low risk characteristics for the poly, because poly wouldn't add any significant information, while ideally p53 mismatch repair genes and estrogen receptor may help in every other patient. We are already doing the mismatch repair, like probably every centers have been doing. We are implementing this approach also for the molecular profiling, but as of right now, it's not a standard of practice.
Great, thank you. So we'll go to our next fellow, Yossi, from Montreal, and he's going to ask Giuseppe Cucinella.
Hi, thank you, Dr. Ramirez. I was wondering how do the study findings contrast with the results of previous investigations, such as those by Dr. Plant and Dr. Bacchus, and what factors might contribute to the differences observed actually in the recurrence rates between these studies?
Thank you, Yossi, for your question. And starting about this topic, we need to understand, and maybe that the comparison of our result to the previous studies is a little bit challenging, because one of the reasons is that the population is a little bit different. Just a reminder of our group of study. We included 42 ITC patients, or are low risk, so endometrial cancer, grade 1, grade 2, and no one had adjuvant treatment, so all had observation. And so this population is small, but is unique compared to the other from previous studies. However, this study, together with the one from BAIX, is one of the largest regarding the endometrial cancer and the ITC. And also we did something different. So we compare with a group of non-negative that have comparable risk factors, comparable profile in terms of uterine characteristic. So going to the two studies that you mentioned, the one from Plente, they showed excellent outcome for the ITC group, 95.5% of 3-year progression-free survival. But then when we look at the population of ITC, they have 31 ITC patients and 10 were stage 1A, so similar to our, and 24 were endometrioid. And then again, trying to find similarity between our group and the group from Plente, 31 patients, of that, 10 receive chemotherapy, 10 receive external irradiation, and 10 receive observational or vaginal brachytherapy. So in total, there are just 2 patients out of 31 that receive observation only, and no one of these 2 patients had a recurrence, whether they were grade 1, 1A. And all the patients, among all the patients, they have 1 recurrence. It was a carcinosarcoma. Regarding the other study, the Bakes et al., that they had a very large series of 175 endometrial cancer ITC patients, trying to find some similarity again. 57% of the Bakes group received chemotherapy or external irradiation. So focusing on the endometrioid 1A patients, there are 47 patients in the Bakes group, and they receive observational or vaginal brachytherapy only, and they had 3 recurrence, and 2 of these 3 recurrence receive observation only. Again, it's difficult to compare exactly these 2 group of patients because we don't really know the exact number of patients who receive observational only in the Bakes, because the authors grouped the vaginal brachytherapy observation only. So it's not easy to compare and to understand why there are some difference, but for sure another factor that we have to mention is that maybe there is a difference by chance because there is a small number of events, a small number of patients in our study, but also in the previous study. So all these factors together may be a reason for these different results compared to the previous literature.
Thank you.
Great, thank you, Giuseppe. Now I'll turn to some of the additional questions from the audience. And Gretchen, I'll ask you, one of the questions was, why was vaginal versus non-vaginal recurrences separately assessed? Do we have a reason to think that ITCs make a difference in this recurrence pattern?
I was really hoping I was going to get this question. I kept thinking, I really want that one. Okay, so this is something we actually talked about a lot. And it's related not as much to what type of recurrence the ITC is causing and more related to salvage. So our vaginal recurrences we know are very salvageable, especially if patients haven't had any treatment with radiation therapy, whereas non-vaginal recurrences, especially if they're distant, are harder to salvage. So we had considered grouping them all together, then we considered separating them. And while of course there are questions about whether distant nodal recurrence especially is more common in ITC patients, really was a question of what is the long-term effect? What is the outcome long-term? That's why we separated them.
Yeah.
Thanks, Brett.
I'll follow that up because it's somewhat a related question. This is from Alexander Shuskevich in Ukraine, who was also a former fellow of the journal. Alexander, thank you for joining. He's asking, did you also look at differences between the surgical procedures and or the use of a uterine manipulator as it pertains to vaginal recurrences?
Great question. So in terms of the surgical procedures, we definitely, total hysterectomy was one of the requirements. So, we didn't have anyone who left cervix behind. We did not look for vaginal manipulators, but there is good data out there showing that vaginal manipulators, using a uterine manipulator of any kind, does not change recurrence risk, does not change LVSI risk. So, that ITC in relationship to vaginal manipulators has not been looked at specifically that I know of, but I do know that it's been looked at in terms of recurrence risk. So that's why we didn't include that. We know there are many different ways to do this procedure, many different people will use manipulators or not use manipulators. And so we thought that trying to cull that all into to information might be hard to do too, but mostly just because we know there's not a difference between the two. But we did require the cervix to come out.
Excellent. Very well. Thank you, Gretchen. And we'll go to Bella Giugelli from Georgia, and she's going to be asking, I think, Giuseppe again.
Thank you. I have a question. Although overall survival was not different between the two groups, follow-up of both of groups were only 2.3 and 2.6 years. Might the result have changed given a longer follow-up duration?
Thank you, Bella, for the question. Well, certainly the follow-up and short follow-up is one of the limitations of our study, but our follow-up was 2.3 years regarding the ITC group, and however, it was similar to the previous publication. Again, Bakes et al. Was 2.6 years, Plant et al. Was 2.4 years. So we don't really have the answer to this question, and as Dr. Glaser was saying, in the prospective trial, we will look also at the follow-up, so at this point. But talking about follow-up, we have shown that the time to recurrence was 1 year after surgery. And also when we look at the overall survival, that was your question, it seems that ITC may has an indolent role, an indolent behavior in terms of overall survival. So maybe yes, maybe not, but maybe the overall survival is not changed. And another point, trying to find an answer to this very interesting question, is that our group is currently working on looking and increasing the sample size and increasing the follow-up of these cohort of patients. So this will be for sure trying to have an answer to that question, waiting, as I said, for the prospective evaluation of the follow-up.
Thank you.
Great.
Thank you.
Thank you. Thank you so much, Giuseppe. And we'll go now back to Montreal, Sabrina Piedimonte.
Right. Thank you so much for really presenting this outstanding study, much needed in the literature right now. So I was wondering, we noticed that the study was divided into 3 periods, so 2012 to 2014, 2015 to 2017, and then 2018, 2019. And the percentage of isolated tumor cells was significantly higher in the last time period. So the difference was initially 4.3, 3.8, and then jumped to 21.9%. And how do you explain this phenomenon?
So thank you for your question. And certainly, when we look at the different rates of ITC by different time periods, we notice that there is an increase, as you say. However, we must remember that this is a multicentric study, and comparing negative nodes patient from one center, Mayo Clinic, versus ITC patients from multiple institutions. Therefore, it is not really possible to compare the rates or ITC by year as part of the learning curve. It's not. It's really part of the study design. The numbers that we see are just a reflection of how many participating institutions are adding ITC during the different time periods. In fact, between 2012 and 2014, we have just 2 institutions that added ITC versus 8 centers from 2015 to 2017 and 12 centers from 2018 to 2019. And so the data are just a reflection of more institutions contributing to ITC in the most recent years. And this represents a gradual adoption of a sentinel lymph node practice in the different institutions during the year, and it's not really a learning curve. But thank you for the question.
Excellent. Thank you so much, Andrea, for that. And now we'll go to Ilaria Capasso.
Thank you so much for the great presentation. So I understand that the challenges in the study design and appreciate the need for controls. However, I'm wondering if having negative controls from a single center might introduce some selection bias. Could this approach impact the generalizability of the findings, given the potential variability in patients' populations and practices across different centers?
Excellent.
I can take that one. Yeah, great. So thank you, Dr. Capasso, for the question. So of course, we acknowledge that having the cohort of patients with all negative nodes from one place is an important limitation. If we could have it a different way, we would. And it may introduce some selection bias. And we're working to overcome those limitations in our prospective trial, having several centers who are willing to send us both patients with ITC and patients with negative nodes in this low risk group. So, but I think on the flip side, it's important to comment that in a population of patients with endometrial cancer grade 1 or 2, negative sentinel lymph nodes, less than 50% invasion, it's really well known that these patients do great. They have an excellent outcome. Intensive follow-up doesn't seem to change that. Over the years, we've removed the things that we need to do during follow-up for these patients and even stretched it out. So in the end, of course, we acknowledge the limitation, but we don't think it changed things very much. We think standardization of surgical staging, using sentinel lymph nodes, the absence of postoperative adjuvant treatment really helped with any potential variability in practice and probably doesn't significantly impact the outcome of this indolent tumor.
Great, thank you. And I think Ilaria had to be very tactful to make sure to ask a question where she would be allowed back at the Mayo Clinic. She
did okay. We're good.
Tough, but not too tough.
Exactly, you got it.
So, Andrea, I'll go back to some of the questions from the audience. This one from Christina Afanasieva. What type of additional treatment should be given to patients with ITCs? Today in your practice, do you perform a full lymphadenectomy? Should there be radiotherapy? Should there just be chemotherapy as an adjuvant treatment?
Frankly, thank you for this question. We see in these patients, when we look at patients with ITC, we see both lymph node recurrences and distant recurrences. And we know this is a general question. If we include all patients with ITC, certainly we include also high-risk patients. And so I would treat what we do right now. Again, we treat them based on risk factors. And if we decide to treat them, I would suggest to treat them as lymph node positive patients. So obviously, if you have a serious endometrial cancer with ITC, I would approach this and I would consider this patient as a stage 3C patient, and so approaching in this way. It wouldn't change the stage, so please don't take me wrong, but the answer is that I would approach this in the same way.
Great, thank you so much.
To change the stage, we'd all be in trouble because then the two would disagree.
Yes,
oh yes.
And we know.
Yeah. That's right. Bring it back to the FIGO committee. Very well. Okay, thank you, Christina, for that question. And next, we will go to Elena Olearo, and she is also asking Giuseppe Cucinella. Giuseppe, they keep going back to you. So, Elena.
Thank you very much. Thank you, Dr. Ramirez. So my question is, in light of the study's finding, I believe it can be interesting if you can tell us how might we tailor adjuvant therapy for cases of early stage, low grade endometrial cancer with the ITCs?
Yeah, thank you, Elena, for the question. Well, the answer is the one that Dr. Mariani has already done, but looking just at the findings of our study, and this is a very important message for all the audience, we need to keep in mind this is a retrospective study, and there are 42 ITC patients. So also, as we know, as the Dr. Ramirez knows, we cannot change the clinical practice based on retrospective study. So we cannot really give like a recommendation, but for sure this is a tough provoking about how to treat these patients, how to follow up these patients. So maybe these patients need a more intensive follow-up. And so the answer is that right now we are treating this patient based on uterine risk factors, so serous or myometrial invasion and so on. And in the prospective way, for sure, we will have more power to state which type of management this patient deserves. But right now, be careful to say something up from this data.
Excellent, thank you, Giuseppe. And I think now we're going to go to the beautiful islands of the Canary Islands. Beatriz.
Thank you. I have another question. Many of interested of Endo ITC after the podcast. Could you give more information regarding this prospective study?
I would just love to.
Perfect setup to sell your
Yes,
study.
perfect setup. Okay, so like we've been talking about, we have designed a prospective multi-center international study, cohort study, called Endo ITC, with the aim of answering this question. So definitively establishing the prognostic role of ITC in otherwise low-risk population with endometrial cancer. So in this study, basically what we're going to ask centers to do is to enroll their patients and then to follow them in a standardized way among all centers without adjuvant therapy. So, so that we can really, again, like we did for this retrospective study, really see the behavior of ITCs, but also be keeping close tabs on those patients. And so, you know, the benefit, if the impact on prognosis is confirmed, like from this study, then patients with apparent low-risk endometrial cancer and ITCs might need closer follow-up for everyone, or might even need adjuvant treatment. Of course, we can't prescribe that based on an observational trial like this, but it would be a next very important step. And then the other thing is, if they don't impact recurrence-free survival, if what we've seen previously is maybe more in line with what their outcome is, then we can more confidently say you don't need extra treatment, you don't need adjuvant therapy. And I think that would make all of us happier to have a more definitive answer for our patients. So obviously, this is a rare situation, you know, only a couple per year, even at high volume centers. And so I just want to put a plug out there that we would love, love, love to have more centers join us. And so we just really want to answer this critical question. I get to turn this into a commercial. We would love to have you join us. So please let us know if your center would like to join us.
Thank you, Gretchen. And by the way, yes, we are joining your study as well. So this actually, great question, actually, from several, Albert Jacobs, Sabrina Piedimonte. I'll ask you, Andrea, any role for quantification of ITCs? In other words, like how many ITCs is relevant? How about bilateral ITCs? We think of these as like very low risk, but if you have them on both sides in multiple lymph nodes, then does that equate to already like the equivalent of a macrometastases? What are your thoughts?
Thank you. And we are looking into this exactly in this population with our pathologists. We are really sharing the slides, comparing pathologists to see if we have an answer to this question. At this point, I don't have an answer to this question. As we know, we have done some studies on the size of metastases, the location of metastases, extracapsular versus intracapsular. ITC, for example, is very uncommon that they are extracapsular. Certainly, I'm pretty sure that we will find something into this, but at this moment in time, I'm not aware of good data that can answer to this question.
Great. Interesting question. Surveillance. Should we do a different pattern of surveillance for patients with ITC? And oh, hi, Elena, I'm sorry, I didn't see this was your question, so I would have let you ask the question. So
no, it's okay.
All right. So should we follow these patients differently, Gretchen?
Yeah, so thank you for that question. You know, what we are doing for our Endo ITC trial, our study, is asking centers to see patients and do a pelvic exam, you know, kind of the follow-up that we expect for low-risk patients every 6 months, and then also do a CT scan at that point to see if there are any recurrences that we can't detect on exam. We don't, you know, there obviously is not a standardized, well-known follow-up system for these patients. And so we're extrapolating from, you know, other kind of tumor types that have this indolent, like a borderline tumor, for example, or a low-grade ovarian cancer, something like that, just to be able to look, knowing that these patients often aren't going to have symptoms when they recur, especially if it's a small recurrence. So that's what we're doing in our practice right now. We are taking all the patients with low-risk endometrial cancer plus ITCs and putting them into the same follow-up protocol, and then asking all of our centers who are doing this with us to do the same.
Excellent. Thank you, Gretchen. And I don't see that there's any additional questions. We have about 2 minutes. I want to thank everyone. And actually, I noted Pernil, hello, welcome to the podcast and the Journal Club. And again, I want to thank you because I think we had the youngest member of Journal Club for IJGC in the audience today. So thank you for bringing him on.
Yeah, he was really curious. He also saw a real nice yellow car in some pictures. So yeah, but he left. ITC was not his style yet. But thanks for very interesting discussions, Giuseppe and everyone else from the Mayo team.
Excellent. Well, thank you all so much for participating, obviously, and to our speakers. You really did a fantastic job, and to our fellows for putting in the time to ask all of those questions. Certainly we want to assure you again that the recording will be available in the journal. And please remember to join us next month. We have the special issue, which is going to be on a topic of surgery in gynecologic oncology. I really feel that you're going to really enjoy all of those articles in the special issues. So thank you all so much for taking time out of your day to join us in the Journal Club. Always great to see you. And thank you once again.
Thank you. It was really fun.
Thank you.
Have a nice day.
Thank
Bye.
you.
Bye-bye.
Bye.